Hello, my name's Debbie. I'm a registered nurse and I'm a PhD student from the University of Leeds. Today, I'm going to talk to you about some research I've conducted as part of my PhD. As a nurse, I readily recognise that how work is done in practice does not always reflect that is written in standards, and I suppose I've questioned what this means for safety. On one hand, and certainly historically, not following standards has been seen as a violation, with an assumption that this is detrimental to safe and effective care. But through a Safety 2 perspective, which views healthcare as a complex system and safety as the ability to succeed in varying conditions, these same policy violations might be described more neutrally as adaptations or workarounds which actually help staff to succeed. I was keen to explore when, why, and how healthcare staff work around safety standards and understand if these workarounds can sometimes be useful to improving care. I've conducted a multiple case study in one large NHS hospital in England. Within this NHS hospital, I selected 3 sites for the case study based upon an interpretation of a framework by Vincent and Amalberti. Using the framework as a guide, I selected a haematology ward to reflect an ultra-safe setting, an elective surgical ward to reflect a high reliability setting, and an emergency department to reflect an ultra-adaptive setting. In these case study sites, I used focused ethnographic methods, including direct observations and interviews, to explore how registered nurses administer intravenous medication. The practice of intravenous medication administration was selected as a focus for the study, as medication safety is an ongoing issue in healthcare, and there are clear standards that govern this practice. Data collection is still ongoing in ED, so today I'm just going to share with you findings from an elective surgical ward and a haematology ward. So let's look at the elective surgical ward. So in this ward, 2 nurses generally look after 10 patients each. Occasionally, there's a nurse in charge whose responsibility is coordinating activity on the ward, but more often than not, this activity needs to be taken on by a nurse caring for 10 patients. The ward covers many surgical specialities, and there are daily bed pressures. The ward's a fairly new ward. It was configured during the COVID-19 pandemic and has been restructured several times since. There are a lot of new staff and a lot of staff with either minimal supervision who require supervision. So in this setting, I observed a range of safety standard workarounds related to IV medication administration, and some of these are captured in the word cloud on the screen. These workarounds occurred in a range of different circumstances. Let me give you an example of the type of safety standard workaround occurring in this setting and describe when it was the circumstances of when it was used. Whilst I do this, try to think about the best way to proceed. Follow the standard, work around the standard, or maybe do something else. So this is the story of the double check admission. It was a very busy shift. There was one senior nurse on duty who could administer intravenous medication. The other nurses on duty were unable to give or check intravenous medication. A patient had become unwell and needed to be treated for a severe infection with intravenous antibiotics. And in this type of scenario, prompt administration of antibiotics is really important. According to the organisation's policy, the particular antibiotics prescribed in this case needed to be checked by 2 nurses prior to administration. The nurse tries to find another member of staff to help with this double check, but has no joy and is unable to achieve this. After some time, the nurse decides that she's familiar with this medication. She's given it numerous times to other patients. The nurse does not want to delay the care of the unwell patient and decides to go ahead and administer the medication without performing the required double check. So it's really hard to know if this was the right decision in the circumstances, and I'll let you think about that. But what is clear in this situation is that the action taken was intentional and thought through, and was performed in response to a problem. The nurse was also clearly uncomfortable with the situation. Now Now let's look at the haematology ward. So in this ward, 3 nurses generally looked after up to 4 patients each. There was usually an additional nurse in charge coordinating the activity on the ward. The patients on the ward are all haematology patients, and only very occasionally would they accept a patient from another medical speciality if they had an empty bed. This ward has been in existence for over 20 years, and several of the staff have worked here for over 10 years or more. They're all very experienced. So like the surgical ward, a range of different safety standard workarounds related to IV medication administration were observed to occur in a range of different circumstances in this setting. Some of these workarounds were the same as in the surgical ward, and others were different. So let me tell you another story of a safety standard workaround I observed. And again, feel free to think about what is the best way to proceed. I'm calling this story the prescription adaptation workaround. A very unwell patient requires several medications and some blood products administering promptly and in a very specific sequence. However, one of the medications has been prescribed orally rather than intravenously, and the patient's unable to take any oral medication. Without receiving the medication that has been prescribed orally, the other medications and blood products cannot be given. The nursing team tried to resolve this by having the prescription amended, but they're unable to achieve this in what they consider to be a timely manner. They therefore choose to alter the route of administration from oral to intravenous and proceed with administering the dose, very carefully documenting what they've done. Again, it is really hard to know if this was the right decision in the circumstances. But in this instance, the patient received all of the treatment they required in a timely manner and went on to have a good outcome. So moving on now and thinking more generally about findings from this study. I'm at an early stage in the data analysis, and I'm beginning to think about how safety standard workarounds are created and considering what this might mean for improving care. So if we look at the diagram, I can give you a summary of my current thinking. And that is that some safety standard workarounds seem to arrive from what I'm calling normal deviance. And by this, I mean from practice, which is routinely done differently to that found in policies and procedures. If you like, it's a sense of how things are done around here. Then there are those other workarounds that are due to latent conditions, and I've split those into 2 circles at the bottom. There are those workarounds that are done due to latent conditions which are potentially fixable, and there are those which are potentially more, which I've called more sticky and more challenging conditions, and these might require a more novel response. I've also been seeing through the data that a single task might be associated with multiple safety standard workarounds, that some safety standard workarounds are common across all settings and others aren't, that only occur in certain places. And certainly not all, but there seems to be some suggestion that safety standard workarounds may be beneficial to patient safety in some circumstances. And with that in mind, I'm planning my next study, which aims to explore stakeholder perspectives on the role of workarounds in achieving safe administration of intravenous medication. And I really look forward to telling you more about that at another time. Many thanks for listening. I could talk about workarounds all day. And if anybody would like to chat about the ideas I've raised today, I'd be delighted to hear from you. Thank you.